Well, let me start by saying, first of all, it's really an honor and a pleasure to be here. When I was first contacted about the possibility of participating, of course, other schedules come in the way, graduations, vacations, these sorts of things. But when I heard of the purpose of this gathering and who was going to be here, I said, okay, this is a priority and this is something that I have to do. So I'm very honored to be here and happy to share some of my thoughts with you. My assigned topic relates to innovations in congenital heart disease treatment and care. Wow, innovation? This is an amazingly huge topic, right? So there's no way I'm going to be able to cover this in relation to the heart. Any of you have read the New York Times the last couple of days. There's a series by Gina Colada looking at cardiac developments, primarily in the adult realm. But I think in congenital heart disease, there is so much exciting stuff going on. There are so many promising possibilities that it really would entail an entire conference, literally, of days of discussion. And there is, in fact, going to be such a conference coming up in Florida in the next couple of months, and a number of different scientific venues to review many, many different exciting areas that are progressing in congenital heart disease. This is a young field. It's still in development. There are still many, many questions. Of course, I have a bias being in pediatric and congenital heart care versus adult care. I think the adults have it easy. It's simple. It's plumbing, right? It's the coronary arteries. It's dealing with cholesterol and those sorts of things. I'm not minimizing the importance of that in any way, of course. But when you're dealing with congenital heart disease, it's a myriad of conditions, different conditions at different ages. And so there are multiple permutations of the types of patients you're dealing with. Different conditions, different ages, patients are going to have different challenges and different potential areas for innovation. So quickly, what are some of the many promising possibilities? New surgical techniques. We just heard from Gus Mavroudis, a major contribution towards prolonging the well-being of many of our Fontans who had an old style of repair, and he pioneered these techniques in the 1990s and early 2000s. Many of these patients now are doing quite well. An example of a new surgical type of new surgical technique, novel catheter-based techniques that I'm sure Dr. Rhodes is going to talk about and review. Valve technologies that are developing. Mechanical support technologies. This was something we couldn't talk about even 5 or 10 years ago, but there are machines that can run the heart, that can provide pumping services at the moment for our sickest of kids, but potentially someday perhaps for our patients with single ventricle who only have one pump, who will benefit from a second mechanical pump. Stem cell therapy, very controversial, still in its early phases. Theoretically a possibility, but no practical use just yet. Tissue engineering, folks are working on this, using one's own cells and planting them onto a skeleton, a scaffolding, to grow natural tissues, perhaps conduits someday, that can then accompany our patients, our kids, putting them into neonates and having it grow into adulthood and not having to replace conduits is something very exciting and I'm sure is on the horizon and coming quite quickly. Nanoscience, the science of essentially miniaturizing things in terms of delivery. Genomics is a huge area right now in the sense of not just the genetic basis to what causes congenital heart disease, which is genetic by definition. Doesn't mean that you as a parent have it. It means that there's something different about the blueprint of these patients, of these kids who have this congenital heart disease. And a very hot area, individualizing treatment. There may be many, many different conditions. We offer a blanket gunshot treatment, but maybe the treatments need to be targeted towards the genetic makeup of specific patients. This is a very hot area, and we're going to see a lot of progress with this coming up in the future. The notion of big data, right? The fact that we now collect minutiae of details that perhaps due to tunnel vision, we couldn't really interpret previously. But when you look at and take a step back and look at broadly at, say, hundreds or thousands of patients who have particular trends in data, there are things that you can learn about how best to manage these patients, how best perhaps to intervene from a time perspective. And then novel drug therapies. So I'm not going to talk about any of these. because there's just so much that's exciting and interesting there. There are two general areas that I'm passionate about, and again, as you've heard, one is doing what we can to prolong the duration and quality of life for our patients with single ventricle and some of the complications they face. And the other is fetal care, and dealing with the patients with congenital heart disease, a birth defect, if you will, before birth. Because I think calling these birth defects today is a misnomer. It doesn't start the minute you're born. Perhaps it's identified when you're born, but in fact, even that's not the case today. In most circumstances, these conditions are being identified before birth, and they start at formation. So let's jump into the prenatal care aspect. It was great to hear just a few minutes ago how somebody reacted for the first time having an echocardiogram done, perhaps as a teenager or an adult. This is something that's done regularly now, thousands of times around the world. This is a fetal echocardiogram, and Dr. Jiyu Tian, our sonographer. Some basic facts about congenital heart disease, all known to this population here. 1 out of 100 fetuses will have some malformation of the heart. There are approximately 30 to 40,000 children with CHD born in the United States every year. 70 to 80% of pregnant women in the United States have obstetrical imaging, so this is visible to a majority of our obstetricians. Whether the skill exists and such, that's still questionable. But it is detectable. And we perceive there to be benefits: prenatal preparation, optimizing perinatal course, and some data that might suggest improved outcomes. A couple of areas that again, I'm going to be biased and focused on simply because these are areas of innovation that I'm excited about and focused in on in some of the work that we're doing, which essentially is to see what can be done once you make that diagnosis of heart disease in the fetus at, say, 16, 18, 20 weeks gestation. Is it a fixed process? Can we modify the natural history in some way so that we can overall produce a better outcome for these patients? So 4 topics I'm going to cover. Maternal stress during pregnancy, somebody mentioned it earlier, in terms of the psychosocial aspects of care, but it begins in the womb, and you'll see what I mean in a minute. Fetal treatment, exciting area of investigating the use of oxygen therapy in mothers to help change some of the structures. So we're going to get into the details of each of these what I think are 4 exciting areas. Improving neurocognitive outcomes through fetal treatment, and then we'll finish up with some aspects of fetal surgery. Here's a little, I hope you can see this. I don't know if we can dim the lights a little bit, but I think you'll get the general gist of this. Here's a little video that was given to me during one of my travels down to South America a couple of years ago. Here's the professor coming in for the obstetrical ultrasound. There's the sonographer. Some of you may have been through this experience. And now here's the resident who comes in, and the medical student. And now they're all looking at the screen, and mom wants to know what's going on. Oh, hold still, hold still. No. And then, oh, now the professor says, hold still. We've got to see what's going on. And, oh, it's not good news. No. Oh. No. So I thought this little video, to me, conveys what I think is the experience that many women have today, which is you're not staring at the screen, you're staring at the face of the sonographer who is doing the ultrasound and scrutinizing every single grimace or smile and of course they're having a conversation. Oh, what a lovely day today, isn't this beautiful? Do you want a boy or a girl? And then suddenly the conversation stops and okay, what's wrong? And this is a common way today in which the moment, the aha moment in which congenital heart disease is detected for the first time. This entire process, starting with this and leading to the birth, is a stressful experience. There's no question. And there's an element of irony here. The irony is that we are making this diagnosis prenatally, and there are potential benefits, there are logistical benefits, but yet we are creating a period of stress for mom and the family from the moment that this happens until the baby is born. And so I think this is a fascinating area that we haven't focused in on, and I think it is an area of innovation from both a diagnostic perspective and potentially from a treatment perspective. There are a multitude of studies out there looking at effects of stressful experiences on child outcomes in pregnant women. Earthquake back in California in 1994, a horrible ice storm in Quebec in 1998, even the 9/11 Trade Center catastrophe. Moms who were pregnant around the time from Lower Manhattan have been studied. And what they found is that maternal anxiety and stress are associated with increased risk of spontaneous abortion, preterm labor, growth retardation, structural malformations, and impaired neurocognitive development. There is a scientific basis to this. Other studies looking at blood flow patterns. When mothers are stressed, this is looking at the maternal uterine artery, which is the artery that supplies blood flow to the uterus. There are changes in relation to stress. Studies have looked at the cerebral circulation in the fetal brain and have noticed changes in the fetal circulation in relation to maternal stress. So we did a study a couple years ago. This was not major news, but we did it within our own practice, and people have known this for quite a while. We tried to characterize and quantify the degree of maternal stress after a prenatal diagnosis of congenital heart disease. 58 mothers were studied at a visit to the fetal heart program at Children's Hospital, Philadelphia. We tested them at 3 time intervals at 26, 31, and 34 weeks gestation. And the testing consisted of a battery of self-reported psychometric tests, something called the Beck Depression Inventory, which is a gauge, is a scale for assessing depression. The State Trait Anxiety Inventory, the Impact of Events Scale, which is a way to look at post-traumatic stress, which is the exact test questionnaire that's used for our soldiers coming back from Iraq and Afghanistan, and something called the Dyadic Adjustment Scale, which is a way to assess for partner satisfaction. And our goals of the study were to identify potential variables that would influence depression, anxiety, and traumatic stress. And not surprisingly, we compared them to a normal control group. The controls in blue. The red are our fetal heart program patients. The significantly increased presence of depression and anxiety in comparison to normal. Interestingly, the partner satisfaction scale demonstrated that in our fetal heart program patients that marital satisfaction, partner satisfaction was less satisfactory than normal. Fascinating area with multiple implications, no doubt. Overall, in this particular series, 10% of mothers had more than mild depression, 20% had clinically significant state anxiety, 28% had traumatic stress scores indicating post-traumatic stress disorder. Again, same sort of thing we're seeing in our soldiers coming back. Higher marital satisfaction was associated with less depression. That makes sense. If you have a strong partnership association, that can mitigate some of the stresses that we see. Higher levels of acceptance were associated with decreased depression, and higher levels of denial as a way to assess for denial through these questionnaires were associated with increased depression. Again, logical things, but again, something that we could characterize in this particular population. Okay, so those are the facts. What do we do with that? Counseling. Counseling is key. Repeated interaction, education, discussion, ways to attempt to try and reduce the stress. We demonstrated within this cohort as well that once we looked at a subgroup of patients, moms, who had serial counseling, that with each of the time points, the number of patients who had traumatic scores above the clinical cutoff were diminished. And so through repeated prenatal counseling, we were able to decrease that stress. What does stress lead to? The stress hormone, cortisol. Okay, many of us are familiar. It's the fight or flight hormone that revs up your physiologic situation. And so the next step in our research here was to begin to look at cortisol in our mothers who are carrying a fetus with congenital heart disease. Again, these are healthy mothers carrying fetuses with different forms of heart disease. And this is unpublished data, a study that we just finished, looking at 60 participants. We looked at 40 patients with moms carrying fetuses with heart disease and 20 controls. And we measured something called maternal salivary cortisol. You can actually obtain salivary samples, and the cortisol content in the saliva very much so correlates with your blood cortisol levels. And looking at awakening cortisol gives you a sense of how much your total cortisol release is. And we compared that to psychometric questionnaires and the severity of heart disease. We found that maternal stress is strongly associated with maternal cortisol levels. So not only is it just the psychological stress, there's a physiologic consequence to being stressed if you're carrying a fetus with heart disease. And then other interesting things, the umbilical artery flow was related to the maternal stress in the control patients, and the disease severity was not associated with stress levels. That last factor is kind of interesting. You might know this yourself. It was sort of intuitive on our part as well, though we were surprised to see it. even if you have minor heart disease, that can be extremely stressful. It sort of depends on what you as a human being and what your makeup is, what you bring to the table in terms of how you respond to any particular stressor. For some moms, for some families, the most severe form of heart disease is not great, of course not, but yet their stress levels were perhaps not as high as some of the other moms. All of this has very important implications. This is from Time magazine just 2 years ago, how the first 9 months shape the rest of your life. A ton of data coming out now that suggests that what my grandmother used to tell folks when she would see pregnant women is she'd, go and, you're not supposed to touch, a pregnant woman's belly, right? But, people still do that occasionally. She would do that and of course, counsel pregnant women about what you eat, what movies you see, et cetera, that it was going to influence the baby in some way. And we said, that's ridiculous, of course, yeah. But it's true. There is data to support the fact that your sense of being, your environment, your psychological state probably does influence the well-being of your fetus. And to what degree does this influence some of the outcomes of our kids with congenital heart disease is a line of research that we're going forward with. Next. I think this shows up. You should be able to see that. So this is our next area of quote, prenatal innovation. It's an echocardiogram from a fetus that was sent to us a couple of years ago where the mom was counseled as having hypoplastic left heart syndrome. There's the left ventricle, there's the right ventricle. And as you look at this, here's the right, left ventricle. What you see is that this wall here is bowing right to left. That's not supposed to happen. If the left ventricle was inadequate in size, if it was truly inadequate, the atrial septum would be bowing left to right, not right to left. So this is something known as an aneurysm of the atrial septum. And it's not hypoplastic left heart syndrome. This aneurysm is impeding filling of the left ventricle. So the left ventricle is underfilled. It's not absolutely small. It's not congenitally small. It's just underfilled. Now, how can I say that? Because watch this echo. Same exact patient at birth. There's the left ventricle. Okay, so I'm taking a presumption here. I assume some of you have looked at echoes before, I'll bet, so you're somewhat familiar with this. But that's the left ventricle, right? How did this happen? Well, simply enough, the baby's lungs opened up, blood returns from the lung, goes to the left side, the left ventricle fills with blood. And therefore, what is a small and contracted left ventricle now expands because it's filling normally with blood. Which then raises the question, can we manipulate this before birth? Can we in some way alter the physiology before birth to fill that left ventricle if we have, say, borderline small left ventricles? Can we change blood flow patterns, realizing that blood flow dictates growth of structures? And so the hypothesis is by giving moms oxygen before birth, we might relax the lungs, increase blood flow, increase blood return to the left side of the heart. So we just published a paper about a year ago looking at this phenomenon in a select group of patients with an aneurysm of the atrial septum, just like what I just showed you there. And we looked at something called the Ferocity Index, which is a way to look at the shape of the left ventricle. And simply enough, we found that with oxygen, there was no change in the right ventricle, but with oxygen, there was a definite change in the size of the left ventricle in these patients with an aneurysm. So we can manipulate fetal physiology in the short term through the use of oxygen. But the question is, can we selectively increase blood flow to stimulate growth of left-sided structures? That perhaps is the next question. And can administration of maternal oxygen increase oxygen delivery in congenital heart disease and potentially improve neurocognitive outcomes in some of our patients? So that's innovation area number 2. Innovation area number 3. In general, this is a statement that's actually taken from the AHA, American Heart Association, recent white paper on neurocognitive outcomes in congenital heart disease. Neurodevelopmental disabilities are the most common and potentially most disabling complication of congenital heart defects and their treatment. Today, we can create survival for most patients with heart disease. That's a given, that's a fact. To a degree, it's a miracle that we've been able to do that over the last 40, 50 years. Now the focus is on optimizing the quality of life of those patients. And what we appreciate is that neurocognitive outcome, not in all, but in some, is a bit of a challenge And there's a wide spectrum to it. Often it's not severe, but it's present in some degree and in a consistent manner in a select group of patients that raises questions about whether or not there's something we can do something about this. What's that neurodevelopmental signature? There are difficulties with attention span, fine and gross motor delays, speech and language delays, sometimes handwriting issues, sometimes impaired social competencies. All of these subtle things contribute perhaps to school performance challenges, which I'm sure many of you are quite familiar with. Developmental behavioral difficulties are likely to significantly limit the ultimate academic and employment opportunities for many of these patients. The simple thing to indict is the surgery, right? These are kids who are sick, they're having surgery, there is cardiopulmonary bypass, the consequences of that. But we now know that that's not the case. It's a much more complex picture than that. Why are there neurocognitive problems in our kids with heart disease? Perhaps there may be some element of contribution in some select patients due to the surgery, but there is hemodynamic stability that exists before the surgery, perhaps even in a subtle way with alterations in blood flow patterns before birth. This is the genetic influence of the response to injury. Right? So every one of these patients has some degree of stressor as they're going through their surgical repair. Perhaps we have genes that make up how we each respond differently to these different stressors. We have some data that suggests that the brain, in a subtle way, is built differently in some of our kids with congenital heart disease. And growing data as well that suggests that blood flow patterns in utero are altered. And again, just one example, this is from the New England Journal of Medicine, not too long ago, abnormal brain development in newborns with heart disease. Again, not all of our kids, but enough of the kids that it makes sense for us to ask these questions. Can we do anything about it? And so here's a bit of a crazy idea, but one that has some merit to it and clearly falls into the realm of innovation. We know that progesterone is a neuroprotective agent. Progesterone is a hormone that is secreted, typically quite prevalent during pregnancy, but it's present throughout life in both males and females, more so in females. But it's been shown that progesterone protects the developing neurons, to the extent that there was recently a randomized trial, this is from the New England Journal of Medicine about a year ago, of motor vehicle accidents. There was a trial looking at neural injury, so people who came in, primarily led out of Vanderbilt, where they would randomize patients to getting progesterone and no progesterone with the notion that progesterone could be neuroprotective once you have an injury in some way. Now, it turns out that the study didn't show a difference in this particular study, but there's a plethora of data that suggests that maybe the design of the study was different and such. The question, of course, is that realizing progesterone is such an important and ubiquitous agent when it comes to fetal development, might it make a difference in our fetuses with congenital heart disease? So we currently have a randomized clinical trial underway of using maternal progesterone therapy to improve neurodevelopmental outcomes in our kids with heart disease. And this is primarily focusing in on the fetuses with heart disease who we think are at greatest risk, the single ventricle patients and such. And so this is being led by one of our surgeons, Bill Gaynor at CHOP. I'm proud to be involved with it, our maternal fetal medicine folks, and we are now we've randomized patients towards either placebo or getting a vaginal suppository of progesterone from 28 weeks in gestation forward, with the notion being that we think that this could very well improve neurodevelopment in our patients with congenital heart disease. So again, an ongoing study, hopefully in the next year and a half or so, we'll have some interesting data to report on. Innovative? I'd say so. I think so. Crazy? Innovation and craziness, there's a fine line. There's a fine line there, but certainly innovative. Now let's talk about crazy. So most forms of heart disease today can be treated very well postnatally. Certainly, you just heard, again, tetralogy of Fallot, the subtleties of attempting to preserve the pulmonary valve, trying to design the initial operation so that you can have the best long-term outcomes and such. No doubt, transposition of the great arteries, we have nearly a fix for that today. We have a very, very good outcome, surgical outcome that's as close to what nature intends us to have as possible. But sometimes we know that there are certain conditions where the situation is such that they are lethal even before birth. And the notion of fetal surgery, the concept of fetal surgery, makes sense. If you can, again, change the natural history in some way, you might be able to improve the long-term outcome. So I'm going to use a model of one particular case and finish with this. This is a very, very rare condition. This is a pericardial teratoma. This is a fetus at about 25 weeks gestation. There's the heart, and there's this tumor that has grown from the lining around the heart. The natural history of this, again, a rare finding, but I'm going to use this condition as an example to demonstrate to you the role of fetal surgery here. This tumor ultimately grows and grows and grows, and it compresses the heart, and ultimately there's a demise. This patient presented to us about 4 or 5 years ago, and just as a forewarning, I'm going to show you some live pathology pictures. So if you're a little squeamish, you may want to look away, but these are some live pictures I'm going to show you coming up here. This is what the heart looked like, and here's what the tumor looked like after about 2 weeks from the point that I showed you the echo. So this tumor grows wildly, and it just compresses the heart, and the fetus dies. We had another case that presented to us about 2.5 years ago now, very, very similar. Back in February 2013, 23 weeks, 24 weeks, tumor again, there's the heart. We knew that this thing was going to grow wildly. And so the techniques for access to the fetus have been developed, surgical techniques. We can gain access to the fetus to repair spina bifida. Some of you may be familiar with that. There was a trial underway a couple of years ago. This is now fairly well established. A number of centers around the world are now doing this. We can remove tumors from the chest. And so in Philadelphia, we have a crack team of surgeons who do this on a regular basis. And we combined our cardiac surgical skills, our fetal echo skills, and our fetal surgery team to say, can we put our heads together and see if there's something we can do about this particular patient? And we did. So let me show you some images of what this looked like. So this is the uterus that you see here. And we've made an incision in the uterus. This is done at 24 weeks gestation. Knowing that this fetus might be somewhat unstable, we removed one of the limbs to place an IV.
Be careful when you say remove one of the limbs.
We put it back. We put it back. One of the limbs taken out from the hysterotomy site itself, and then who do you get but your best neonatologist to come up, for this 24-weeker to put an IV in. So we got an IV put in, and then again, Bill Gaynor, one of our surgeons at CHOP, scrubbed in, and then a sternotomy performed to open the chest. So the limbs are up here. The head and the rest of the torso of the fetus is still in the uterus. So the fetus is not fully exteriorized. And then there's the tumor, slowly being removed. It was large enough that it actually needed to be cut into sections before it could be fully removed. And then my role is to watch the heart with echo while this is ongoing. And here you see the heart, the tumor sitting on the heart itself. Why is this important? Because we know that once you relieve the tamponade, the pressure effect on the heart, significant changes can take place. Here you see the tumor now removed. There's the right ventricle. And then immediately we saw some evidence of significant valve regurgitation as a consequence of the removal. Fortunately, with sort of giving some blood and stopping the pulling and tugging on the heart, this resolved within about 30 seconds. And so we were able to continue forward and remove the rest of the tumor and closed up the rest of the pericardium that you see here. Fetus put back into the womb, the uterus closed, fluid replaced, and then the baby delivered at 38 weeks gestation through a cesarean section. This is what the heart looked like at a follow-up echo at 3 months of age. I wasn't expecting that, but thank you. That's not. So the right ventricle here looks smaller than normal, right? So you would expect the right ventricle should be larger than normal. And the reason we think, even though the baby was completely asymptomatic, is because the tumor was probably impairing the growth of the right side of the heart during an important period of time of gestation. but the heart was functioning completely normally. And here's the little guy at 3 months. And then I got to see him in clinic. This is about 2 months ago. It's a family from Vermont, so they now come down annually for a visit. And so here he is, the only survivor that we are aware of with a giant pericardial teratoma who's undergone fetal surgery. Innovative, crazy? Probably both, yeah. So, in conclusion, my predictions for innovative treatment in the next 5 years from a prenatal perspective, very limited window, right? We could talk about many other things, but in this particular area, managing maternal stress to improve child outcomes, I think is something we're going to be focusing a lot of attention on in the coming years. Maternal oxygen therapy to alter heart structure. There's already talk amongst many of the fetal groups in the US to develop a consortium to do a multi-center study to look at maternal hyperoxygenation at 28 weeks in our borderline small left ventricles, where we often argue, is this going to be a two-ventricle repair with a coarctational repair, or are we going to have to do a stage reconstruction? Strategies to alter fetal brain development and improve neurocognitive outcomes. There's talk potentially using caffeine, using magnesium administration, as well as our trial, which is currently underway using maternal progesterone. And then fetal surgery, but only for select conditions. But with these sorts of things, I think there are lessons to be learned as to how to potentially see how we can change the natural history of congenital heart disease before birth. Thanks for your attention.